committee, but we do have for the executive. Thank you. Item 3 on the agenda, declarations of interest. Do any members wish to declare any interests in any agenda items? No, shaking heads there. Item 4. So this is regarding the minutes from the last meeting. The minutes have been documented from the meeting on the 11th of September. No matters of accuracy have been notified to the monitoring officer. Are you content that I sign the minutes as an accurate record? Yep, everybody in agreement. That's great. Thank you. So item 5 is regarding questions from members of the public, and we have no questions received at this point, so we'll move on to 6, which is from members of the council. Have we had any questions? No, we haven't. Okay, so that was pretty swift. So now we can get into the meat of the meeting, and this is item 7 on the agenda, and it is regarding domiciliary and home care. The purpose of this is to provide us, the committee, with an overview of the home care services in Herefordshire, both commissioned by the council and the wider market. The report also outlines plans to support hospital discharge arrangements over the winter and provides more information on the council's shared lives services. So we can move on now to the presentee, and I expect that's going to be Hayley to start.
Thank you, Councillor Crockett. Yes, so we have submitted the report, which, as you mentioned, gives an overview of the home care market. So we're going to take you through a short presentation to just highlight some of the salient points of the report, looking at the home care market and the work that we're undertaking jointly across the commissioning team and our adult social care operations. We're going to then talk about discharge to assess and the work that's currently underway with our colleagues through health and again adult social care and commissioning to review the pathways and the work that we're doing around discharge to assess and making sure people have the right outcome when they leave hospital. And then Ginny will take us through the remaining slides looking at shared lives. We've also got Bron, who's joined us today on virtually on Teams. Bron is our quality lead, so we'll be able to pick up any questions relating to quality of services as well and our processes in relation to that. So if that's okay with everybody, I'll ask Sally to take us through the first part of the presentation. Sally.
Hayley, can I just ask you, would you like questions as we go or at the end?
At the end would be great, but if you do want us to stop at any point, please just say, we can pick up there.
Good afternoon, everyone. I'm Sally Wilson. I'm the interim head of care commissioning at Herefordshire Council. I'm just going to take you through the slides around the home care capacity and delivery. The report that we presented to the committee has hopefully been received and helpful. As Hayley said, we're going to talk about home care in terms of the capacity and demand that we have in terms of the market, some of the challenges and opportunities that we're faced with in terms of managing that market and the delivery of services to people in Herefordshire. And we're also going to talk very briefly about some of the challenges we have around self-funders within the market in terms of how we're able to understand that and manage that. Then we're going to talk about discharge to assess, which is the process for people being discharged from hospital, how we look at the demand for those services as people need that support, a review of the processes and the service model that we've been undertaking, and also talk about how we're getting ready for the winter. It feels as though it's getting here very quickly. And finally, Ginny's going to talk about shared lives in terms of the service and what it currently delivers, and also the developments in terms of how we're looking to take that forward. So moving on to home care, just in terms of some of the legal framework, I thought it might be helpful for people to understand the duties under which we provide home care. So the Care Act 2014 replaced a lot of the previous legislation that was in place that was quite fragmented, and it gave a clear duty to local authorities to meet assessed eligible care and support needs. And that delivery of that care and support could be through direct provision of care and support, through commissioning that through a market, or it could be through enabling people to purchase those services themselves through a use of a direct payment that would be funded by the council, where people didn't have their own funds. Or it could be a mixture of the two, so some people could get directly commissioned services, or could a direct payment for certain elements of their care and support. In terms of the types of services that can be used to support people, that can either be accommodation in a care home or some sort of other premises, support at home or in the community, which is where the home care service fits within that area. It could be in relation to counselling or other type of social work where people are provided with support from social work teams. Provision of goods and facilities, and very much in terms of all those are things like technology-enabled care, equipment, adaptations, things like that. Or it can be purely through the provision of information, advice and advocacy. Those are the types of services that we can provide support through the Care Act. The Care Act also places a responsibility on councils to shape the market and to manage that market. There's a requirement for us to make sure that we have a sustainable and diverse market, that we improve quality and choice as we're managing that market, and that we look to actually create better opportunities, innovation and cost-effective outcomes through the delivery. So there's quite a lot of different responsibilities that we have that all play part in how we manage the market around home care delivery. So just a few facts and figures. Headlines are that in Herefordshire there are 49 home care providers currently operating in the market, with around 2,200 people supported. It's a little difficult to get precise figures on the numbers of people supported by the wider market because we don't have a responsibility for those people who are privately funded. Some of those numbers include some cross-border provision. That's why we can get information around what the companies are providing overall, but actually some of the companies operate between both inside Herefordshire and Gloucestershire and some of our neighbouring councils, so we're not clear what the split is for some of those, but it's around that sort of region. Within that overall market, the council then commissions 34 of those providers to provide services directly to people requiring care and support. That's for 600 people roughly at any one time that we would be commissioning support for, and that's a total of around 8,000 hours that we would be commissioning in terms of those services. Home care support, that includes a range of different things for support that can be provided. Personal care, medication support, so aids and prompts around when people need to take their medication. Activities of daily living such as help with food preparation and things like that, and also access to the community, so people can receive home support to actually go out and access services in the community. Within that group of services, personal care is actually classed as a regulated activity. Providers who are delivering personal care have to register with the Care Quality Commission, and all our providers operating in Herefordshire are registered with the Care Quality Commission for personal care as part of that home care delivery. It is quite a fundamental part of what we expect our home care services to deliver. I'm going to talk a bit about the commissioning arrangements now that we've got in Herefordshire. So pre-November 2021, there was an improved list of provider agencies under the Care at Home framework. These are referred to also as legacy providers that you'll see in the report. That included 28 active providers who were operating in Herefordshire prior to 2021. Those providers could operate wherever they wanted across the whole county. What we found though, there was over provision in some areas and under provision in others, and some challenges therefore in the market. So in November 2021, there was a decision about changing the way that we operated and the way we were trying to manage that market. And we brought in a new home care framework that actually divided the county into 4 geographical areas that went within the framework as what we call lots, but it basically is 4 different areas. It limited the numbers of providers operating in each of those areas, and it also limited providers to only operating in 2 of the areas. So there was a certain number that could operate in each area, and then each provider only 2 areas. And there were 11 providers appointed to that framework. This slide shows you a geographical illustration of what those areas represent, where those boundaries are, and the numbers of providers in each of those areas that are operating. So they vary in size, but that partly is about the numbers, so that there was some work done to think about what the optimum size of the different localities and how they split between rural areas and more urban areas. I think it's fair to say that the new framework addressed a lot of the issues that it was set up to address, but actually there will continue to be challenges around insufficient capacity in the market to meet the demand and the needs of the people who required support. And they were largely the same. There were a lot of national issues that affected that were being seen elsewhere. So there's a lot of recruitment and retention challenges in the sector. A lot of that was around the impact of COVID on the care workforce. Also some issues around Brexit that were impacting on the workforce. I think the slides I'm going on to talk about later around overall challenges talk about the sort of geography of Herefordshire and how that added extra complications into the market. In November 2022, therefore, because we were starting to see this challenge and increased impact of not having enough capacity, a decision was taken to open a secondary framework. That was a different type of framework. It was a framework that was established to enable us to open it periodically. That meant that we could look at challenges in the market over time and then reopen the framework and bring new providers on as and when we need to. Since we put that framework in place, we've actually opened that up to providers on 3 occasions, in December 2022, February 23 and May 23. Through that process, we've actually, an additional 11 providers have joined the framework, and they have actually had a significant impact in terms of additional capacity to the market, those providers.
Sally, could I just very quickly interrupt? It was just a question I had when I was reading this. Are these secondary framework providers tied to the geographical areas in the same way that the primary ones are?
No, they're not.
No.
No, they're not. And you'll see from the next bullet point, actually the impact significantly from those, but not solely from bringing those providers on, has been to reduce the waiting list for care from 100 in April. And we've updated the figures on the slides from those provided in the report. As of last week, that was reduced down to 24 people waiting for care and support, which is a significant achievement in a small amount of time. Providers that have come onto the market are still growing and establishing their businesses, so we are looking to ensure that we continue to develop that market and to reduce those numbers down further. This slide just gives you an illustration of the numbers of providers on the different frameworks. So we have 11 providers who are on the original framework 1, which have the bulk of the market. So they have nearly 469 clients at the time we did this picture, and as I say, the bulk of the hours. The framework 2 providers are just the ones coming into the market. They've got a far smaller proportion of that market, but they have tackled some really challenging areas for us geographically in terms of where we've needed to put that capacity. And then the smaller cohort of providers are those in the legacy providers who've got the smaller number and a reducing number of clients. But interestingly, the hours that people they're supporting continues to remain proportionately relatively high as people's needs have progressed. In terms of quality of provision, really pleased that in Herefordshire the majority of the provision of those that we contract with are in the good and outstanding bracket, and we only have one provider that is in the required improvement category, and these are the ratings that are given by the Care Quality Commission. Obviously these are done a range. They're not always they're the current ratings, but there will be an amount of time that's lapsed between then when they were last inspected. So things aren't always, things do change, and that's where the council's quality assurance team actually play a vital role in terms of assuring that quality in between.
Sally, can I just add something there, because I'm not sure whether everybody understands the abbreviation RI.
Sorry.
So it requires improvement, just for anybody who didn't know. We're trying to get away from doing things like that.
Abbreviations.
Right.
Yeah.
Thank you. But it's a good number, so that's good.
It is. It's very good. Very positive. In terms of legacy provision, this just shows you over the period of time the pattern that's changing with those legacy providers, which were the providers who were on the old framework before November 2021. So the numbers of providers are reducing as their client base reduces. Numbers of customers are reducing, but actually the numbers of hours are not reducing proportionately as much, and that's because as people's needs get older, quite often their needs progress, and therefore those providers are providing slightly more care to slightly fewer people. We've then got this diagram that might seem quite busy, but actually this shows this change from when the specification was being developed for the for the framework in the new framework in 2021, the estimated numbers of people and hours that was expected to be supported. So at the top two rows show you the overall totals for Herefordshire. And what you can see there is that whilst the numbers of people have remained lower than anticipated, the number of hours that actually were estimated in April 21 and what was delivered in September 2023 were actually fairly close. And that's mirrored, I think, with you look down to each of the areas. Similarly, there's a similar pattern there where the numbers are lower, but the hours are fairly in line with what was estimated at the time. And I think that's generally around, we're experiencing more people with more acute needs, more. Yeah.
Thank you. And looking at that downward trend, could you say a little bit about what you think is driving that? I mean, is that because more people are self-funding, or why are the numbers going down? I would have thought the numbers for care would be going up.
I'm not sure that if you look at it, was the estimate as to what was estimated as we put the new contract out. I think they thought the numbers of people were going to grow. If you look at the April 21 figures, which is the fourth column long, that's slightly lower than it is now, so the numbers haven't reduced overall, but there have been peaks and troughs over time. I think it's fair to say. Do you want to go? Thanks, Mandy.
I think what we do see is, for example, with our discharge to assess arrangements, our numbers do go up because pre-COVID we didn't cater for the amount of people that we're seeing now. But as we assess people into the right pathways, into domiciliary care or into residential nursing placements, then you see people, those numbers come back down. And of course, a lot of self-funders are then in their own funded pathway. So overall, I think we are seeing higher acuity coming through, but once everybody's been assessed and back into the same pathway, we are managing demand in that way.
This is another unfortunately busy slide, and hopefully it's probably hard for you to see the numbers, but you can probably see the trends in terms of what's been happening over really the last sort of couple of years, and 18 months, is it? Trying to work out how many years we've got there. So it just shows how the patterns are changing. As you can see, the more recently what we're seeing is an increase in the numbers of people and the numbers of hours again, as we are starting to bring that capacity back into the market. But you can see that I think the trend from April 2021 it has shifted a bit in terms of the levels of support and the numbers of people supporting. In terms of the finances, you'll notice from this there's always an increase every March, and that's to do with and that's to do with our usual annual fee increases. So within the market we set fees for home care at standard rates. We have an urban rate and a rural rate, and every year we will undertake a review of whether or not those rates are sufficient to meet to actually be able to afford the cost of care. And we do market exercises to understand the pressures on providers, and also some benchmarking around what other local authorities around the region are paying in terms of benchmarking. So we will then reflect that in what we think is the right rate to pay. So we are currently going through an exercise to start looking at that for next year's fee rates. So whilst the numbers are slightly fewer now because of the numbers of hours have increased, we're now seeing an increased cost pressure. So the reduction in waiting lists has had a financial consequence in terms of the cost of provision of home care. There has, as a result of some of the reduction in short-term residential care, where we're having to place people in short-term residential, we've actually been able to reduce some of the costs involved in that, but that's not shown on this chart because this is just showing the costs of home care. So just a bit more about the waiting list, really. As I say, in April 2023, there were over 100 individuals on that waiting list, and we've now brought that down to 24. That's been managed through I think during those waiting lists and how we've supported people whilst they've been waiting for us to be able to identify and bring that care on board. We've provided a sort of a mixture of Home First, the councils, the Hoople Cares Home First service have taken on some of those high-risk cases and provided support in the interim for some of those. We've also had to look at some short-term care home placements to provide support. Some people have had home care but just not at the level that we'd assess them for, so they've been getting some home care support. But there has been needed to be a reliance more on informal carers, families, friends to supplement some of that care or to provide that care. Those informal carers, family and friends would probably have been the people who've been supporting those individuals anyway until we undertook an assessment, but it will have put in additional pressure. So in terms of the impact of, obviously there will have been an additional strain on those informal carers. Could have had impact on relationships, potential distress of temporary moves away from the home environment where we've needed to place people in residential care because of those risks that we felt couldn't be managed in their own home. In terms of the council, there's been the cost of that alternative provision where we've needed to put that in place. And there's also been the impact on staff and staff capacity through that in terms of managing the demands of that waiting list. Very proactive risk management approach from the operational social work teams. Work involved in seeking alternative temporary provision where that's been necessary, and that's been both in terms of the social work teams and commissioning, and also a lot of work being done by commissioners in terms of developing that market and trying to put in place the capacity that was needed to meet that demand. So just a couple of last slides on home care, and one was around sort of the challenges which I mentioned earlier. Recruitment and retention, major national issue. There's information on in the report from the Skills for Care report that actually undertakes analysis of recruitment and retention issues for the market as a whole. So this is about sort of the difficulty competing with other sectors in terms of paying conditions is one of the major factors that we struggle with capacity in the care market. And that's not just home care, it is care workers generally, so care homes, supported living and home care. The nature of the work, what's required in terms of it is a tough job for people, quite often working in isolated conditions. And also international recruitment has been a challenge, both in terms of some of the impact of Brexit, that caused some challenges around international recruitment, but then some of that's eased, and now that we're looking to encourage some of that international recruitment into the market. The other issue is a demographic issue, high numbers of older people, and some of these are national issues in terms of we've got a growing ageing population, but actually some of these are compounded in Herefordshire because of the nature of the demographics here that are slightly different, so that we have got a higher number of older people. The over 65 population continuing to increase at a high rate, especially over 85s, who are often the people who are requiring care and support. We've got a high number of older working age adults, which means that a lot of that population will be exiting their working life, and therefore if we're not bringing new younger workers in to replace them, that causes a challenge. And there's a low proportion of younger working age adults, especially in Herefordshire, which means that we've got a significant issue around that. The rural sparsity and geography of the county is also a challenge for us locally. Fourth lowest population density in England. More than half the population living in rural areas, and in those rural areas even more compounded are we by the gap between the older age range and the younger working adults. So how do we get provision into some of those local rural areas? And poor road networks and isolated properties are also a challenge for our care workforce. The other issues around a large private funder market in Herefordshire. So we don't know. We know that the scale between what we commission and what's available in the market is around over 1,000. So we commission less than 50% of that overall market, which means that it's very hard for the council to manage those providers collectively and influence the market as a whole. So we have to, a lot of the private funded market, they're not necessarily all people who've met the sort of thresholds you would for council commission service. So some of those people may be actually purchasing lower level care at potentially higher costs, and therefore how do we balance that with what the council needs to wants to commission, and that enables providers to potentially choose and pick where they want to work, and what where their workforce is as well, and what their workforce are prepared to do. In terms of our response to the challenges, that's been led predominantly by the introduction of the secondary framework. We are supporting recruitment and retention across the workforce through the Herefordshire Cares initiatives. There's also support from the West Midlands Association of Directors of Adult Services around recruitment and retention of overseas workers. We've got a lot of work that Jane and her colleagues have been doing around improving relationships with the sector, holding regular provider events and forums and meetings, very much taking a you said we did approach to addressing issues with those providers, working and co-producing solutions to problems that we've got collectively with those providers. So there's an example where one of the providers that Jane has been working with has been about actually developing a provider to work in an area where we actually really have very little provision of home care, and they've actually now been able to take on the whole of that market in that area, and providing we no longer have a waiting list in a particular area there. Also developing the links with strengthening links with talk communities around the use of community hubs, trusted neighbours initiative, and signposting to community activities. But then I suppose the major one has been the management of those risks around the waiting list, and what we've done collectively with our operational social work colleagues to really work on that list, to understand the risk, to prioritise what's being delivered, and to minimise the impact that that's having on individuals. So a range of initiatives that we've done around that. Next steps, we're planning for the recommissioning of the home care framework. So the framework that went in place in November 2021 expires in 2025. In terms of a lead-in time to delivering a different model or recommissioning that, we need 12 months minimum because of the level of disruption that could create in the market. So we're starting to plan now for that, ready to make sure that is a smooth transition, that it's well managed. Also, what will influence that is our project to review and further develop home care solutions. So we're looking at our existing model. We're investigating good practice from around the country, what are others doing, what's working, looking at then doing an options appraisal and a business case as to how we take those things forward, and implementing new models. Some examples of what we're going to look at are around better deployment and use and encouragement around personal assistance and micro providers. Very much a focus on maximising independence in everything that we do, with looking very closely at what we do in terms of use of technology and equipment and adaptations to continue to support people at home. Immediate next steps are about maintaining and continuing to build those relationships, to continue to onboard the new secondary framework providers that are just joining the market still and need to be supported to embed within Herefordshire. Looking at how we help our providers to develop rounds and better utilise their capacity and resources, increase utilisation of the community assets for care staff, and we're doing a lot of work with Home First in terms of developing their service model and capacity, which I'll talk about more in the part on discharge to assess. I don't know if you want to stop for questions on home care there and move on to the next section, or whichever.
I think it'll give you a break for a minute. So
thank you.
Thank you very much. Thank you, Sally. I was just thinking, I was really fortunate to be the cabinet member for the previous administration, so I know exactly what we've been planning, and I thank Hilary and the team, and obviously Mandy and Hayley for all the hard work. And it really is, it's encouraging to see such improvements over those last few years. You know, it's such a difficult area, isn't it, to manage? We've got so much flexibility with population, etc. But I do thank you all for your work. I don't know whether Councillor Powell would like to add anything on the children's side of it at any point this afternoon, but feel free to jump in if you've got anything to say. Committee members, any questions regarding home care at the moment?
Yep.
Councillor Davis.
How do we assess and ensure the quality of care provided by our domiciliary care providers? I know as CQC assess them, but do we do anything council-wise to monitor and maintain that?
Yes, we do. We have a number of quality assurance officers within the team that is led by Bron, who's joined us virtually. So we do have a very robust quality assurance framework, whereby we make sure in between CQC that we have regular contact with the provider, and we also undertake quality visits. So if I just hand over to Bron, do you want to explain the process of how we do that?
I'll try, yes. Good afternoon, everybody. It's Bron Williams, and I'm Commissioning Support Unit Manager. So within my team, I have 3 separate divisions. One division is the broker team, who broker all the placements for adult care in care homes and dom care, supported living, etc. I have a quality assurance team, which is split into 2. So part of the team are doing adult services, the other part of the team are doing children's services. And then equally importantly, I've got contract support officers who are doing all the administration of contracts, etc. So the 3 all work very closely together. So in regards to quality assurance, our primary objective is to ensure that adult social care providers and placements deliver quality services to people in Herefordshire. And as Hayley has said, we achieve this through a robust quality assurance process. We're evaluating information and intelligence on a continual basis. We do positive challenge with our providers and to our providers, but we also work collaboratively with them to improve care practice. Our quality assurance systems, etc., work across all of our services. So there isn't a separate quality assurance process for care homes, and there isn't a separate one for dom care. So we use the same process throughout. All of our commissioned services receive a minimum of an annual quality assurance service review. So we have sight of all of our providers at least once a year. We support all services to provide assurance in the quality of placements being commissioned, providing varied opportunities for adults to link in and to be connected to their communities, which is most important. Delivering care that reflects safe, effective practices and maintains quality as a high priority. We have well-maintained professional partnerships supported by good leadership. That's what we're expecting from our providers. We also want them to deliver high quality and safe care, which focuses on person-centred outcomes. And we also want all of our providers to achieve at least a good rating, CQC rating, if not outstanding. We do have some outstanding services in Herefordshire. The stages of our quality assurance process are largely fall into 4 areas. So the first areas are going to be defining quality. So all of our services have service specifications, so our contracts have those. We have key performance indicators. We expect to see a whole host of policies and procedures with our providers. We also use core assurance principles when we're going out to visit our service providers. We're also always sharing and signposting resources and educational support to them. We proactively share best practice by encouraging all of our providers to access all learning materials that are widely available to them, examples of which are Skills for Care, CQC updates, etc. Second part of our process is to measure quality, and we use a whole range of things here. Intelligence gathering and collation from respective stakeholders. We also have a lot of information provided to us by CQC on a monthly basis, where we go to check our ratings, any changes in managers, etc. We also have the NHS National Capacity Tracker. We use that for intelligence for staffing numbers and absences, an example of which we went to a provider last week, and the capacity tracker was showing they had eight vacancies or 8 staff absences, which was 50% of their total number of staff. So when we questioned it, we discovered it was a mistake because the service can't run on 50%, etc. So we are checking all of those things on a regular basis. We take the views of individuals receiving care and support, and we use a lot of intelligence from our operational colleagues in regards to that. And we have lots of risk matrices to support informed decisions of approach. And all of our information is reviewed on an ongoing basis. We have lots of intelligence from our safeguarding colleagues and quality concerns notifications, and we also look at lots of compliments and complaints as well. We have a monthly safeguarding meeting, so that's a monthly meeting with Safeguarding, Care Quality Commission and QA, where we discuss various issues with providers and aspects, and any concerns we might have we want to highlight and escalate up to our Care Quality Commission colleagues. We have provider self-assessment questionnaires we want our providers to complete before we visit them. We have lots of monitoring visits, and we're always encouraging our providers to develop and record a report using their own internal service development plans to improve their quality. From this, my team then determine what next steps, and there's a whole range of steps from a full quality monitoring visit to a desktop review to unannounced visits, etc. When we're supporting our providers to improve quality, we have very clear service development plans with them with clear actions and timescales, and we're always constantly testing those for sustainability and practice embedment. And it's all through structured, consistent, regular reviews and monitoring. If all of that fails, we then have enforcement, where we follow the QA framework levels, and within our quality assurance framework we have 3 levels. One means we won't be taking any action at all because it's a good provider, they don't have any service developments to be monitored. 2 is when we sort of do more than a light touch approach. So we're working with our provider collaboratively to help them and support them to improve. And if they get to level 3, that's when we have to take formal suspension, etc., and have strategy meetings with the provider to determine what we're going to do next. Pleased to say that most of our services we manage within levels 1 and 2. And as I said, occasionally when a service is unable to improve or where safety concerns are a high risk, the service provider will move to a level 3 of the QA framework, and we do formally suspend all new business. I think that's probably about it. If there's any questions, thank you.
There was the question on the provider that was required improvement. How are we supporting that organisation to develop their improvement? Do we have a lean into that? Because it's a CQC, I assume, issue in the first place. However, it's relevant to us as a county.
It is. Can I just, with regards to the Care Quality Commission ratings, let me just highlight the facts, and I think Hayley probably touched on it, or Sally did, that CQC inspect and visit providers not necessarily on a regular basis. So there are a number of our providers, particularly in the care home market, who maybe requires improvement, but that's because their inspection was done some years ago. And CQC are, by their own admission, quite behind on doing their inspections. They're looking at inspecting services that haven't been inspected since 2017. In regards to the home care provider who's currently requires improvement, it is one of our newer framework providers, and we are working very closely with them to monitor all of their improvements, support them with those improvements with resources and advice and guidance. And we're meeting with them on a very regular basis, a weekly basis at this point in time.
Thank you for that answer.
Okay.
It's a bit worrying that CQC could make a decision on something and then not follow it up if they say a provider requires improvement. Surely there's something that should be done sooner rather than leaving it for numerous years before action being carried out.
One would hope so, but we do have regular meetings with CQC where we are passing information to them or sharing information with them on our provider market. So all of that information is taken back, and Care Quality Commission do risk profiles. So every month they do look at the risk profiles of all the providers, and any intelligence they receive, which could be negative or detrimental, that then increases the risk profile of the provider. And then they have management review meetings, which will pull forward a provider if they feel it's necessary for them to go out and inspect. But frequently within all local authorities, I think the Care Quality Commission do rely heavily on the information and intelligence that we provide, including our service improvement plans and actions and the monitoring that we do.
Thank you.
Thanks.
Thanks for that, Bronwyn, because listening to your reply, it occurred to me that whilst that early bar chart showed that so many of our providers are ranked as good, given what you've just said, the flip side of the coin is that actually they may have been ranked as good some years ago, but actually a more up-to-date assessment might find them requiring improvement. So it's a bit of a double-edged sword, isn't it? So I think I'm reassured from what you've just said that probably our monitoring is perhaps a little more up-to-date, and I won't say more stringent, but certainly more up-to-date and more relevant. And there's lots of nodding heads, so I'm very, very pleased to see that. And given what you said about the monitoring, can I ask, without assuming, so it's a question, it isn't an assumption, that many of those same criteria are used when we are selecting new providers, or do they go through a quite a separate process? Although clearly many of those criteria would apply for somebody who is new as well, I assume.
That's a question I'm going to pass to my commissioning colleagues, because that sits with commissioning and not quality. Sorry. But
Thanks,
thank you.
Bron. Yes, so we do undertake those processes when we are appointing new providers. So we go out with we will have a very robust specification in terms of what we require, which includes standards for safe care, etc. And also we go through due diligence process in terms of checking CQC ratings and the viability and sustainability of the company through that process, working very closely with our procurement colleagues. So there are checks at the start before we appoint a provider to the framework, and then the processes that the quality assurance team use come into play as soon as that provider is up and running.
Councillor Bartlett.
Thank you. And just following on from looking at our providers, and obviously we've got legislation around that. We've just talked about CQC, quality assurance. What about compliance with additional relevant regulations? And I'm thinking here very much around the modern slavery laws. There's been quite a lot in the press recently around the country's workforce in this sector, possibly sometimes being, I wouldn't say duped into the contract they've got, but they're not being treated as well by the people that have got them into the role as they could be. And I just wonder where we are on that part of the workforce, looking out for those that may be working in our care homes who might not necessarily have the tools at their disposal to make sure that they got the right contracts and the right conditions, etc.
So we work very closely with the providers, as Bron's outlined, and as part of those checks within quality assurance, we do understand the makeup of the workforce for each of the providers. So we're always aware if there are workers from overseas, etc. We also, across the team, are linked into various forums with West Midlands ADAS, West Midlands Association of Director of Adult Social Services. So there are various forums, and each of the providers where they have overseas recruitment need a licence to do that. There are national processes around the licences, and we work with our regional colleagues to look at providers where there are concerns in terms of the way that they're recruiting overseas workers, or concerns in terms of the conditions for the overseas workers. So we feed into the intelligence around providers as we take on the intelligence as well from our regional colleagues, because a number of providers will work across the region. So we're linked into all of those forums, and there is sanctions that can be taken against providers if they're in breach of those their licence conditions to employ overseas workers, and we would take that very seriously and work through our escalation routes for quality assurance if we had concerns in that way for overseas workers.
Thank you. That's reassuring that nobody's being exploited here. And so, yeah, so I think actually I'll leave it there, because the other questions I've got slightly unrelated to that.
Can I just add something? Really, it's on the other side of that same question. So how do we ensure that domiciliary services are accessible to all residents who have diverse needs and different backgrounds?
So in relation to that question, at the point of commissioning, we undertake a quality impact assessment, working with colleagues in the council to make sure that we recognise all of those diverse characteristics that we need to consider in formulating the specification for the service. The specifications will be formulated as well, taking on feedback from people who use services and providers, and working very closely with our operational colleagues around the emerging needs for individuals and how we design the service. And then as part of our commissioning process, we ensure that the specification then is written to make sure that we can meet the needs of all of people that we may need to meet the needs for diversity across the county within the specification, and then that would be also monitored through our quality monitoring assurance.
Any other questions at this point, or shall we move on? Kevin?
Yes, of course. Since you mentioned feedback, how does it work from the other direction, so to speak? Are there fairly clear mechanisms for service users or families, as well as the providers, to provide feedback. I mean, I think Mandy probably will remember that fantastic meeting we had during lockdown with a number of the providers, the heads of the companies, and it felt like there was a bit of a pent up, not quite a tidal wave, but certainly a seven bore of complaints and niggles that they then had the opportunity, because we were all sat round the Zoom screen, and they could direct their pent up frustrations and complaints. Now, obviously, when you have that opportunity, that will always happen. But we would like to think, I'm sure, that there's a pretty good feedback opportunity for everyone, and I don't just mean the heads of the provider services, but families and service users themselves. Almost, a complaints procedure, if you like, to be able to, if necessarily, bypass the providers and come straight to us and say we're not happy with what's happening, and so on.
So from a provider perspective, in terms of the engagement with providers, we've been working really hard, and Jane's been leading a number of forums over the last 12 months to work with providers. So we do have a regular forum now with providers where they can talk to us about any niggles or concerns or any aspects. So Jane has been working really hard on that, and there's a number of examples where we have local forums. We also have joint events that Jane's been leading between where providers come along with some service users, and we gather feedback through that, and very much have been working on a co-production model with providers and service users and co-producing solutions to some of the issues. If there is any specific complaints, they can come through our complaints process. And Mandy, I don't know if you want to say a bit more about that in terms of individual clients, if they have specific concerns.
Absolutely. People can come through directly to the complaints process, but we also have quite a very good dialogue with families and individuals that they can also come directly to us. We're also going to be introducing an external process so that we can directly contact people, but not from a social care or a commissioning, but from a, so how has this been for you? Either the assessment process and making sure that we're capturing everything that we should through an assessment process, but also through that the provision of the services has happened in a timely way, that it meets the need. So we're going to be directly approaching people in the future to ask a range of people that ask those questions.
Thanks. Because obviously it's a difficult situation, isn't it? Because it's not a two-party relationship. It's three, or with the family, four, and yeah. The stories are not always consistent, and also you don't want to damage relationships. But it certainly was one of my lasting memories, quite frankly, from the whole of the previous administration, was that meeting. And if you find that this committee is setting up a repeat exercise, it's my fault for being too evangelical to my colleagues about how incredibly useful it was. Not just from our point of view, I genuinely think it was really useful from the providers. But thank you, Mandy.
Any other questions at this point? No? Councillor Bartlett?
Yeah. So on Domcare and the provision that we have, or we're required to have, you touched on discharge to assess and the getting people out of hospital and back into the home or into the pathway that they need to be in. And I just wondered whether you could say a bit more about how we work with the hospitals, and also in terms of the financing behind it. So where we sit with the Better Care Fund, and whether or not we feel well enough supported in the roles that we've taken on to get people into the right places where they get the best care that they want when they're coming out of hospital. And also, Mandy, I know we've talked quite a number of times about the continuing health care fund, and I just wondered if you could say a bit more about that side of the financial partnerships that we have.
So the next set of slides is specifically on discharge to assess. So would it be helpful to do those slides and then pick up the questions on discharge to assess?
Yeah. Can we just make sure we've covered everything home care that anybody wanted to ask before we move on? Yeah. The one thing I will just add is on the second slide, I think it was, it quoted technology-enabled living, I think it was. I don't know whether, have you got that to bring back up or not? No, don't worry. I just wondered to what extent technology has been utilised in, oh, here we are, is it on there? Or is it not the second one? Okay, don't worry. So to what extent is technology utilised in managing and improving our domiciliary care services? You know, technology is changing every day, isn't it? So I know Lee Davis leads on it, and I think he would be really great to come back to this committee with his next stage, shall we say, because he's very enthusiastic and he is succession planning all the time. So is there anything you want to add? Thank you, Jane.
Yes, we're working with Lee Davis's team, and they're doing some technology pilots, and they were looking for people that would be willing to be guinea pigs, for want of a better word, to try out some of the technology. And we've put the providers have gone back and looked at their customer base to see if there was anybody willing to be part of that pilot. And we've got them coming again to one of our meetings on Wednesday to just say what the technology is all about, and if there were people that were willing to test it in their own homes, they could subscribe to the pilot.
Thank you. I think that would be really good to add that to scrutiny management, yeah, in the near future. Okay. Thank you. Yeah, and I think Councillor Tillett's got another little question.
Well, it's sort of two parts, and it's to a certain extent about the future. Before we move on, in 4.29 in the report, it talks about the work that you've done enabled a provider to open a new office in a new location. The advantages of which are obvious. I don't know if you wanted to either give us a bit more meat on that bone, but in particular, just thinking about the future, and I have got a second question on that subject. Was it just a very fortuitous one-off, or is it something that you think, you know, has got legs and could be repeated elsewhere to fill in these black holes or these geographical areas that are difficult to serve?
I think it's quite, each of the challenges we find are slightly different, and we need to approach them in a slightly different way. We did work hard. It was a provider who was, you know, has been a good partner provider, I think it's fair to say. Probably brings more to the table than just being a standard provider. They're keen to work with us and develop, and they did very successfully tackle that particularly challenging area for us. Whether or not that would work across the board, I'm not entirely sure, because there needs to be enough of a market in an area to make that viable for a provider. So it has to be a certain size, and some of the areas where we're struggling really are because of the sparsity of the population. It's a little more tricky, I think, in some of those other areas. But yeah, we always try and learn from what we've done that's worked and see if we can adapt it elsewhere, but it's not always possible, I'm afraid.
No, I understand that. It's just it sort of leapt out as well. That's almost a completely different way of solving a problem, and it would be great to try and build on it if the opportunity. And my last point on this, and I'm looking directly at the director, is that, and I know she has recently made a statement or some guidance on this in another forum, but I think it would be useful to make this part of this meeting. Don't look so uncomfortable, Hilary. Is that a bit of an elephant in the room, in the sense that for much of the last 4 years, money has been sitting set aside for the council to run its own facility. It went very quiet under the previous administration towards the end, and really it's still very quiet. I think it would be really useful for there to be a clear statement, not necessarily even from you, but perhaps from Cabinet, about exactly where this project is going, what the plans are, where we are, and so on. And I'm not putting you on the spot necessarily to say it now, but some clarity on this, because clearly this changes or would affect the whole of this scenario significantly.
I wondered where that was going to go then, Councillor Tillett, but it's gone
I'd
in
like to keep you guessing.
It's gone in a really clear direction, and Hilary will expand.
So there is a lot of work going on in the background to prepare the business case for a potential care facility that the council could run itself. The original proposal was looking at a care facility for older people, but we're doing the work to look at whether actually a better investment of the council's resources would be in a care facility or some form of facility for people with complex learning disabilities, challenging behaviours, high-end autism, because they tend to be the people, unfortunately, we don't have provision within the county for, and we're often having to send them out of county to placements, which doesn't feel the right thing to do. We want to maintain those local connections. Actually pulling that data together to get it into a business case that makes sense is taking the time. So that's why it seems like it's gone quiet. I can assure you it isn't quiet in the background. Once we've got that business case, then we will be coming forward, and Councillor Gandy is fully aware of it, to ensure that we can put whatever provision is needed within the capital programme going forward. And in terms of Cabinet, it has been part of a wider discussion at with Cabinet colleagues, and there is support for looking at what we can do going forward. What we do know is that in terms of older people and care facilities for older people, the market is quite saturated from a private market point of view in terms of that. And so what we've been exploring is whether actually the better value or better use of the council resources, as I say, with that perhaps more complex, higher end needs, and how can we then build a workforce that supports that? So it's kind of got to, it's both that local connection for people to stay in the county, but also potentially building a skilled workforce, improving the workforce and the opportunities for people, local people within the county. So it's quite complex, but I can assure you the work is ongoing.
Thank you, Councillor Tillett. As Hilary's just said, nothing's gone quiet. It's still ongoing in the background, and I think, you know, these last 4 years plus have really thrown some spanners in the works, shall we say, with different challenges. We had Brexit, and then we had COVID. So it was definitely the time for a review and refresh to see where our needs are going and that we can meet them. So thanks, Hilary. Councillor Davis.
Just a quick question on technology front. I was impressed with what you said, Jane, and I'm really happy that we're driving it forward, because I think it's going to be a real benefit. The downside is we're such a rural county, and the Wi-Fi connectivity in rural areas, and even in some of the city areas where elderly don't have Wi-Fi, don't have internet access, the ability then to use alternative systems to gather that information and data is going to be crucial. Is there any plan for that?
As part of the technology project, yes, there is. They're using alternative forms where there isn't Wi-Fi. I'm not a technical person, so I can't tell you exactly what it is that they're doing, but yes, they've taken that into account, because not everybody has Wi-Fi in their house either, you know, through the fibre system. So they've taken that into account when they've looked at the providers that are providing the technology, that they've got that covered off.
Any more questions on home care or that domiciliary market? No? Okay, thank you very much. Would you like to continue? Have you had enough of a break, Sally?
Yes, that was lovely. Thank you. And thanks to Hayley for answering all the difficult questions. So this is just to talk a bit about discharge to assess, with focus on the home care elements of discharge to assess. So discharge to assess was introduced in March 2020 as a response to the COVID pandemic, and its main purpose was about expediting hospital discharges through that difficult period. Some of that work, once that model had been implemented through the COVID pandemic, it then continued for most local authorities, and that there was an acceptance that that was a good model in terms of getting people home quickly and hopefully or getting them into longer term care provision quickly. So in 2022, the Health and Care Act came in that actually revoked what was a previous requirement to assess for long-term needs prior to discharge. So discharge to assess was a very different model to the way that the legislation had been set up to manage discharges previously. One of the other core changes in that act was around a duty for NHS trusts to involve patients and carers in that discharge planning at the earliest possible opportunity, so that it wasn't done at the end of somebody's stay in hospital when all of a sudden there'd be a conversation about where were they going and how were they going to leave the hospital. So that needed to happen earlier in that person's, in the planning of the person's journey through the hospital. And then the hospital discharge and community support guidance that was issued in July 2022 made it very clear that there was an expectation for system partners to work together and implement a discharge to assess approach, with very much a home first approach, which I think was probably a bigger shift in that, in terms of it wasn't just about discharging to assess out of hospital, it was about focusing on getting the person home as well. And it was based on that evidence through the period before, from COVID experience through more settled times, that was a better and more effective way to ensure the safe discharge of somebody from hospital, making sure they were out of hospital as soon as possible. That meant that, you know, because it's not actually good for people to be in hospital for longer than they need to. So this is about, let's get people out quickly and then do the assessment when somebody's in a more stable situation, when they're out of hospital in a more normal environment, I think, for most people. And that was a better place to assess their long-term needs. So that's a bit of the background to the sort of changes to the system and the legislation. In terms of the pathways, there are 4 recognised pathways through the discharge to assess guidance. Pathway 0 is for those individuals who don't require any additional support. So they may have been getting some support before they went into hospital, and they may require the same level of support when they come out, and they're still on pathway 0. So it's either people who don't need any support at all, or are returning to their usual level of support and usual place of residence. Pathway 1 is for those individuals who need some additional support at home, and that is around, they would then return to their home, or they might need some short-term support to enable them to continue living in their own home whilst they're supported out of hospital. Then we look at pathway 2, which is the one about sort of, this is your short-term reablement, rehabilitation in a care home setting. So these are the people who are leaving hospital. The plan is that they'll need a short period in a care home to assist with their rehabilitation, and then they would move on to hopefully return home. And then pathway 3 is about those individuals requiring long-term care. In Herefordshire, we're also looking at a continuing healthcare pathway, and that's, I think we've been talking about that as being pathway 4 in terms of how does that look and what's the journey for somebody who will require continuing healthcare, and what's the assessment process for people out of hospital on that journey. So we have a range of services that we currently support, commissioned to support discharge to assess. So there is a block contract with Ledbury Intermediate Care Unit for nursing care beds. We also have a block contract with Hillside for residential care beds, and that's around that short-term rehabilitation support out of hospital. We then have care provision within the market generally, so care homes that, you know, we spot purchase beds for people as they are discharged from the hospital. That's also a key part of the discharge to assess support. We then have Home First, which is the reablement and rapid discharge service home from hospital, or that also provides other services from the community as well. And then we have home care services within the market generally, where people are discharged from hospital straight into straight to a provider in the home care market. Currently, there is also a bridging service at the hospital that I've forgotten to put on the slide, that supports people also in terms of some of that home care capacity from hospital on a very short-term basis whilst we are waiting some other availability. So it's really sort of bridges the gap. We've done we've been doing some analysis of the activity around discharges from hospital to various settings, and this has been in terms of I've focused these slides on the home care elements of this. So in terms of in 2022, that was from January 2022 to December 2022. Analysis of the activities that were happening at point of discharge from the hospital. There were 870 referrals into the home care service over a 12-month period. 140 referrals in addition to that directly for home care. So 800. So you're looking at over, you know, nearly just over 1,000 referrals into the system in terms of people requiring support at home. Of the 870 referrals that went to Home First, 300 of those referrals were screened out as inappropriate. So that's a challenge in terms of making sure that those pathway decisions from hospital are accurate. I think that's fair to say. Of the, there were then the 370 discharge to assess placements that commenced with Home First in that year. And there were a further 170 that commenced with home care providers generally. The figures will never match exactly because we've got changes with the actual people who are through the system in the 12-month period. And some of those people who may have been referred for a service at home due to challenges around capacity may have gone into short-term care home provision to expedite some of that journey as well. In terms of, we've utilised a lot of the intelligence and information we've had in terms of looking at what are our best estimates of future required activity in terms of supporting people at home following discharge. So the estimate is between 500 and 550 people will require discharge to assess support at home in a 12-month period. The average package size somewhere between 10 to 14 hours a week. 14 hours a week generally is, you know, 4 half-hour calls or some sort of makeup like that in terms of what somebody might need. So an AM call, lunchtime call, tea time call and bed might be sort of a typical sort of package that you might see. And that equates to between 5,000 and 7,700 hours a week of care that would be required to support people out of discharge. And then I've just tried to put some context there in terms of, if you recall the previous presentation, in terms of the overall support that we are commissioning from the market was around for 600 people at any one point in time and 8,000 hours per week. So it's a really, the discharge activity, some of this will be different because the Home First service wasn't captured within that overall market. The other market looked just at the external provider market. But it just gives you an illustration that a significant part of the market that we are managing is impacted by the hospital flow. And the other things we've yet to understand properly is how those peaks and troughs happen. So we've looked at the activity over a 12-month period. What we haven't yet properly got the information to understand this. So is, you know, I'll come up with a theoretical fix, is 65% of that activity over the winter period and 35% during the rest of the year. How does that work in terms of the system where, you know, there are always peaks and troughs, and therefore demand and capacity to match the capacity to demand is quite challenging without understanding that part of the system flow.
Can I just ask, sorry on that, when you talk about future demand, is that future demand going into the future, or is that the near future, or is it on an upward trend?
That's based on that's the demand based on the 2022 best estimates of demand based on 2022 activity. We're not expecting a significant shift in that in the short term, and we need to really understand as we track this and model it through the next 12 months, how does the actual demand differ from some of the analytics that we've got historically. So yeah, it's
I've got that. So that's a specific point in time future
Yes.
demand, and each year that will reinforce and
Yeah.
what you think's going to be coming at you further down the line. Thank you.
Okay.
Can I ask, who decides, you're talking about pathways, who decides, and is all the pathways then council funded? Obviously, once they leave the hospital doors, is that all council funded?
Right, so who decides is a multidisciplinary team approach, but that multidisciplinary team includes family and the patient. So what happens is that as people's journey through the reason why they're in hospital in the first place is reviewed, and as they look as if they're starting to look towards to being discharged, the team gets together and then decides, is it straight home with a care package, without a care package, or is more reablement needed? That's pathway 2. Or is it looking as if we need a further period where we of bedded care where we can properly assess somebody as to whether they're going to be able to go back home with perhaps a complex care package, or whether they'll need to stay in bedded care for quite a further period of time. So those decisions are then made by that multidisciplinary team, but including consulting with the patient clearly and the family members.
And funding?
The funding element is we have a discharge to assess fund through the BCF funding criteria, and that is reviewed every year. We're just going through that period now of deciding what that funding is, how much that is, and what it covers and what it entails.
So would the family be asked to help funding wise?
Not for people who meet the criteria for discharge to assess. They wouldn't be expected. So periods of reablement, absolutely not. They would receive that care and reablement free up to the point where it's determined that they don't, up to a period of 6 weeks, or it might be 1 week of funding, 2 weeks of funding. It depends on the assessed needs and meeting those reablement goals. Other people might be assessed as actually being able to move to a funded pathway directly from a community hospital, for example, where it's established that all the assessments have been done and a long-term placement is needed. Then you also have the people that are self-funders anyway and had a care package before they came in, and as long as they don't meet the reablement criteria, then they can resume with their usual care package and self-funding pathway.
So just a little bit more about Home First and the block contract. So as well as discharge to assess, the Home First service provides crisis supports for individuals that are referred through the Community Integrated Response Hub. That is an urgent response to people living at home that just needs some intervention to enable them to remain at home and possibly not be admitted to hospital or need longer term care services. It also acts as a crisis support and reablement support for individuals referred through the council's locality social care teams. And I described earlier how how Home First had responded to some of our shortages in the system overall in terms of packages of home care, where we'd got the waiting list, and actually we'd managed some of the pressures on the waiting list and the risks to individuals by placing those people with the Home First service. And then they also provide this rapid response reablement support for individuals being discharged from hospital. And we do also have a small number of individuals that have been supported on a longer term basis by Home First that have been individuals that have been really challenging to find alternative care and support. And that might be because of challenging behaviours or geography where we really have struggled. So in a lot of places they call this service like the provider of last resort when we can't find anybody else to support somebody, and we would ask the Home First service to provide some support on a longer term basis for some of those individuals. What we've looked at is some modelling around the capacity that is within the Home First service and what they may be able to support on a in terms of that, their capacity overall. Sorry about that.
Sorry, it was on silent.
So if what we've looked at is the three elements of service that the Home First service provides support. If 40% of that capacity was targeted towards discharge to assess, that they can achieve a 70% contact time of that workforce, and that's negating for so that obviously they've got to travel distances across the borough. There's travel time, there's training, there's holidays, sickness, etc. that we have to take account of. So 70% contact time is quite a challenge for people in the home care sector, I think, to deliver at that level. If the average package size was around that 10 hours a week, and if their maximum length of stay in the service for those people requiring the reablement approach, that short-term intervention is sort of around 4 weeks, then they should have capacity to support all those discharges out of hospital. So we are working on a programme now with Home First about how we support them to deliver and test the feasibility of them being able to deliver to that model. We can't really say, well, you've got 20% of your workforce, 40% of your workforce just working on this, because they spread their workforce across the geography of the county, and they need to operate with more generic teams. But we're working with them to try and move to that model currently. In terms of our preparation for winter, as I say, we've been running the discharge to assess processes now since the COVID period. Over this summer, we commenced a piece of work about let's review those models, both in terms of the processes, make sure that they're the best models and delivering what we need to, but then also the actual what are the services that people need at the end of that journey, and have we got the right capacity in the right places, and are we commissioning that in the best way to support people coming out of hospital. So we've got a multidisciplinary group that we've established. We're getting people focusing on how do we move people into long-term care provision quickly, so that we've not got the level of disruption. Where we can, people should move directly into that, back into that long-term or forward into a long-term provision. So we minimise the numbers of different changes in somebody's package. How we support self-funders to access long-term care as well within that model. So as I say, there's a lot of work being done around improving and refining the current processes. We're also looking at the revised delivery model, so we're looking at the specification of the services that are being delivered by HOOPL, the Home First service, being clear about what we expect from that service, looking at how we improve the management of the referrals going into the service, identification of alternative provision in the market for overstayers, so that helps the flow through the Home First system, so that people aren't staying in that service too long, so we get the length of stay down to that 6 to 4 weeks, rather than some people are staying in the service for a number of months, which isn't the right place for them to be supported. Looking at reviewing rotas and shift patterns for workers within the service, and around introducing charging for long stay clients that remain in Home First for whatever reason. Good news is that a couple of weeks ago now we were informed that we'd been successful in each local authority had been allocated amount of what was called the Local Authority Urgent and Emergency Care Fund. The allocation for Herefordshire was just over 400,000. We put some proposals forward for use of that money, and we heard a couple of weeks ago that we'd actually been successful, and they were happy that we used the money in this way. So we're looking to put some additional brokerage capacity in. That's in Bron's team to help support the placement of individuals and get them into care services quickly. Additional social work capacity around working weekends, so that when we come to the Monday morning, we've not got a backlog that we're trying to deal with to help support people through the system. We've looked at some additional commissioning capacity to work with HOOPL on the development of the Hillside unit and the development of the Home First delivery model, and also some partial funding of additional block beds over the winter to ease some of those current pressures through the system. So we're just now starting to move forward with recruiting to those posts and moving that additional capacity through. That will really, I think, support us getting the new models embedded. I think that's the end of the discharge to assess.
Thank you again, Sally. Any more questions on discharge to assess? Councillor Bartlett, did you want to add something else?
Yeah, I mean, just and thank you. Apologies first for preempting your slide set, and thank you for filling in an awful lot of the gaps on that. So, understanding BCF, Better Care Fund, how that feeds into to what we get, and that very much goes with the question you were saying about where does the funding come from and what the split is. Are we doing well in what we need from our partnership through the Better Care Fund? And then the other one was going to be about the continuing healthcare funding. Very pleased to see about the extra money that we've got, and that we're doing weekend support now, because that makes a huge difference. So on the back of that, how do we perform in terms of helping the NHS, our hospital, not have their beds blocked, if that's the phrase? So there's kind of those three questions. Thank you.
I think I captured the gist of your question. You might have to repeat parts of it, but how we. So if I look at continuing healthcare first, to start with, it's not just continuing healthcare. I would give a sort of broader definition, because people come out of hospital utilising different funding streams for health, and continuing healthcare and how we process that as to whether somebody's eligible after going through a checklist and a decision support tool, which is the mechanism for for CHC. There's also the fast track process, which is for people that are very poorly at the point of discharge, and the continuing healthcare process, which doesn't happen in a an acute setting. We have what's called a fast track process, so that funding stream for people who really are quite poorly, and it should not be social care funding, and it's not the discharge to assess funding work stream either. Will go through that health funding stream. So there's that people tend to forget about. Then there is the potential of continuing healthcare funding, and social care works with our health partners on that to make sure that that if they're not eligible for this continuing healthcare funding path, then we would pick up obviously anybody that we should and take them through that discharge process. Other elements around making sure that everybody is working together is that I think health absolutely understand that it's not just about the discharge process to make sure that that we've got maximum and appropriate use of the funding streams. It's about getting that decision right at the point on the ward. So what the hospital are really quite committed to at the moment is, as we are reviewing currently the funding pathways for discharge to assess, they're also looking at their ward responsibilities and their ways of making sure that everybody who can go home without a discharge to assess process absolutely does so. I mentioned earlier people returning from hospital, returning to their nursing or residential placement. At the moment, those people are coming through our discharge to assess processes, and of course that doesn't need to happen. So with the right information and commitment and capacity at the point of discharge on the ward, they will go directly home. And that was the original process that people remember before COVID happened, is that people who have got their care packages or are self-funders and don't need reablement actually go directly home without the process that we've currently got. So we're working very closely with health at the moment, making sure that we're looking at all these practices, making sure that we've got all the information that staff need, health and social care staff that are working within the hospital, so that we can absolutely get the right decisions and using the right pathways and funding as effectively as possible. Don't know if you've got anything else to add about BCF.
Yes, just in terms of the BCF, obviously the BCF covers a number of schemes under the Section 75, not just the hospital discharge. So there is an allocation within the BCF that is around funding the services for hospital discharge, whether they're provided by the council or by the hospital, because the bridging team and hospital to home services are hosted by the council, and the LICO contract is managed by the NHS. So that's the Ledbury Intermediate Care Unit. So that's managed by health. So there's an allocation within the BCF, but the BCF is much wider in terms of a range of health and social care services that we support. But we do meet on a weekly basis. So Mandy's part of the Silver Call to make sure we're moving people through the flow as quickly as possible to make sure there isn't any block beds at the hospital. We do know that in the last couple of weeks it's been particularly busy at the hospital, so there's been significant pressure over the last couple of weeks. So there is a weekly meeting as well around the discharge services, where the council and the Health Wye Valley Trust colleagues and our ICB colleagues come together to look at how we are working together and moving things through as quickly as possible.
Yeah, thanks, Hayley. And I know our partners do work in conjunction with us in a really good and positive way. Councillor Thomas.
It sounds a marvellous idea, but what's going through my head, coming from, I keep saying to everybody, from commercial background, there's an awful lot of management in this, and what is being done to keep this management within sort of control? Because, you know, you're talking about groups, a group of people that assess and it all sounds that it's slightly top heavy. I don't mean it as a criticism. I just mean it as an observation. But what's been done to keep this in check?
So when I was talking about it's a multidisciplinary approach, it doesn't necessarily mean that everybody's going out and seeing that person, but it may take an occupational therapist to take a view and a physiotherapist to take a view before a decision is made about what is needed on discharge. Some of those therapy goals will be started at the hospital, the community hospital, wherever appropriate. But that's what I was meaning by a multidisciplinary approach, that it can take a range of assessments to really make sure that we've got the optimum opportunity for the patient to recover and rehabilitate.
Do these assessments all, are they basically the assessees all in a room together, or are we looking at paper assessments so that, you know, one person, occupational therapist, will say, yes, this person requires A, and then does that sort of one person then make a decision so that it doesn't become, as they say, top heavy?
There are meetings every day that will talk about where patients are at. That would be a matter of course that a range of professionals would be at, but it wouldn't necessarily mean that there would be individuals coming in and saying this is the assessment.
Councillor Tillett.
This is a much more basic question that I think I believed was answered in my brain some time ago, and I'm just want reassurance that my understanding of the changes since 2020 are quite clear. Are there circumstances where people's assessments are occurring after they have left hospital, or are the necessary assessments being done before discharge rather than being discharged to then assess?
There are different types of assessment. So the two that absolutely no longer legally need to occur, particularly the one is, from a local authority point of view, is a Care Act assessment. So the legislation was brought in with the Health and Care Act in 2022 that changed changed our duty to assess people in hospital under the Care Act 2014. So whilst we can do it when we absolutely think it's necessary to do it, we don't have to anymore. That assessment can take place once people have left. So yes, you might have an OT given a view, or a physio and a social worker putting together a description of needs for people so that we can absolutely confirm the right pathway that people are on. The assessments itself, that Care Act assessment, the continuing healthcare assessment, if it's not an appropriate time and place to do it, we no longer have to, as we did with the Care Act 2014 pre-COVID. And for that little bit of gap of time between COVID and that legislation taking place, we were sort of out of kilter with the discharge to assess process, but the government has changed that now. So we're in the position that we can discharge to do those assessments. But that doesn't mean that we're not taking a view on people's needs at that point in hospital and describing the level of care that they need so that they can have a safe discharge.
Okay, I'll declare. I understand. I thought we had moved beyond that. You know, so the scenario that happened in the previous timeline, shall we say, and this was some time before, and it was not in this authority. Let me make this quite clear. The situation where my father was discharged from hospital, and when he died at home 13 days later was still awaiting assessment, could technically still occur?
So if a person in Herefordshire needs care and support, the the plan is for them to be discharged home to that care and support. And that might be, say, for Home First at work, that might be with Home First on Pathway 1, it might be into our other resources like Hillside, LICU, or it might be in another residential and nursing home. And then those full assessments would take place. But
I just wonder
if you've got health and care, you wouldn't be discharged.
I think this is what
Without
Councillor
care.
Tillett's asking, you know, what the concern is, I think you're asking, is that nobody goes home without what they need.
Or at
basically.
least a knowledge of what it is that we need to provide for them.
So
And
then
I kind of thought D2A had sort of moved us on past that scenario where you go home and we'll get someone out to you as soon as we can.
Yes, that's absolutely right.
That we have moved beyond that.
Yes, we have definitely moved on that, and that there would be a health and care plan for them for when they're discharged, wherever that is, whether they're at home or they go to somewhere temporary into bedded care.
the assurance is the safety aspects of it all, and I'm sure from the conversation, hopefully you're okay with that.
I thought that was the situation. It was just some of the things that were being said. I thought, hang on, have I slightly misunderstood that the situation hadn't, if you like, improved as much as I thought it had? But thank you for reassuring me and our many viewers.
Councillor Davis.
Thank you, Chair. A question on the funding stream. After discharge, there are 4 pathways, and those pathways should allow us to use our funds in a better way to ensure that the individual gets the individual care they require, irrespective of whichever pathway they go down. My concern is that with an ageing population, is that being taken into account that in future we might need greater funds to provide the same level of care to our ageing population?
I think that's a tricky one, isn't it? And Hillary's going to take that one on.
Yes, I think I stepped forward or everyone stepped back. I'm not sure which. So what we do know over the last couple of years is we've had additional, what they've called adult social care discharge funding that's gone into the Better Care Fund. That's been distributed according to need. So we have, we've had proportionately less than Worcestershire because of the size of our population, but we have had some additional funding, which has been specifically to support discharge from hospital. I think the longer term funding of adult social care is a huge issue generally across the country, adult, ageing population or otherwise. And I think there's been a report launched today by the County Councils Network, which has been specifically focused on the hospital, but does reflect that ageing population dynamic as well, or demographic as well. So I don't think I or anyone has necessarily got the answers. I think what we are seeing is increased demand, we're seeing increased acuity, and we're seeing costs increase. So inevitably the pressures are there, whatever we do. And it's whether we see a change in terms of that reform funding that we were expecting through the government, or whether that will not materialise in the way we thought. We know some of those plans have changed. I can't give any assurance here today. We can only plan on the basis of what we know, and do the best that we can within the resources we've got and use them in the most efficient way. I think one of the key things for me is that we are looking at alternative models. We're not just, you've heard home care described, we are looking at different ways, different potential solutions that we can use. That's not just about the money, that's actually about ensuring that we've got equity of access and provision across the county. That can only go so far, and clearly funding is a key part of it, but I don't think anybody could give assurance that we've got the funding sorted, and I think it will inevitably become a bigger issue as we go forward, and as colleagues have described today, what we are seeing is that acuity of need, getting both the acuity and the complexity of need of people needing our care and support. and we have to do the best that we can within the resources that we've got. So
Thank
it was
you.
a bit of a downer, but it's the best I can do.
Thank you, Hilary. Because there's been so much debate about the discharge to assess process, etc., I think we should consider putting this on our management plan in the future on the work programme. So I think we need to bring this back at some point so that we can bring Hoople and Wye Valley into the meeting to have a longer discussion. Yeah. Okay. And just one other comment. We keep mentioning the ageing county population. We mustn't forget that there are a lot of us who are over 65 who are ageing, yeah, but we're not a drain, hopefully, on the resources, and we can support them, she says. Okay, no other questions on that. Shall we move? Councillor Bartlett.
So, well, one last question on the last two pieces. I'm assuming the third part of this is going to be about shared lives. Yeah. So I'm in the right place this time. Thinking about who needs to be supported where and how and by whom. How confident are we that we're always making sure that nobody falls through the gaps? So earlier we were talking about having something like 20, 30 people who were waiting for a package or a path that we knew they needed. So when it comes to the rurality of the county, and particularly those people who need help, who are on their own in out of the way places quite often, as well as those that might be in the city or the town, how confident are we that through our network we're making sure that nobody falls through the gap and somebody somewhere is looking after people if they need it?
That has to be our one priority. Our number one priority is making sure that we have safe and effective services. That's whether they're discharge services, assessment services, where people also transfer from whatever care that they've had in hospital, for example, to a care package. So all our efforts, whenever right now with the discharge to assess process, where we're currently reviewing everything, is to ensure those safe transfers of care, that safe and effective discharge. So that is within every plan that we have, to try and ensure that no gaps happen. And so we're working with all our partners. Operations work with commissioners, so that we're integrating in a way, also utilising the primary care network as well, and their part to play in helping to keep people safe and in whatever care pathway that they happen to be in.
Thank you. And so if they don't necessarily qualify for our funding, they're not self-funding, somebody somewhere through that network will be making sure that their low level, on the cusp needs are being picked up so that they don't deteriorate and end up being missed.
That's a huge that is a huge ask, and I don't feel I can sit here and give guarantees for the general Herefordshire population, but if people are known to us and they are coming to our services and we know about them, and we then, whether they're funding or self-funders or not, we would look to support them in whatever way to make sure that they've got a safe network around them as possible.
Okay. All right, thank you very much. Are we all right to carry on, or does anybody need a break? No, we're all right. Okay, Sally, I don't know whether you're going to run this or is it Ginny It's your moment of fame. Thank you, Ginny.
Yeah, hi. So, shared lives. So a bit of background. What is shared lives? Shared lives is a very person-centred form of care and support. What makes it so person-centred is that an individual is matched carefully with a shared lives provider who then shares their life, their home and their interests with that person who's eligible for social care. I would just point out that historically we've talked about shared lives carers. Here it says shared lives provider. That's a deliberate attempt for us to try to instill that these are people providing a service and not informal carers, really, which has been a misunderstanding quite often. So shared lives enables the person to live safely and comfortably in an ordinary household in their community of their choice, and it offers both long-term and short-term arrangements. And when we talk about short-term arrangements, you might think of that as respite for families. Shared lives can also offer what we call shared days, which is about people spending their day in a shared lives household, as opposed to a day service. In Herefordshire, Herefordshire Shared Lives Service was insourced back to the council in 2018. Important to say that Shared Lives is a CQC registered service, but it's not regulated in relation to accommodation. It's regulated in relation to personal care. So as a registered manager, that's me, I have legal responsibility for the quality, safety of those arrangements and a duty to monitor the care and safeguard the people receiving care. Also to assess and approve the shared lives providers, and we support the clients also to agree and review their individual shared lives plan, which is a sort of continuity from the assessment that a social worker will do, putting it into an action plan of how within shared lives that person wants and needs to be supported and what outcomes they want to achieve. So some key facts for you, just a few. In Herefordshire at the moment there are 46 shared lives households. Within those households there are a total of 67 approved shared lives carers. I should actually say that these figures are over the sort of 6-month period from April to October this year. We also have 18 support carers. Those are people who can step in if the shared lives carer needs to go away or have a break. They can step in and support within the main home of the shared lives carer, so the person doesn't need to go anywhere else. We've had 60 long-term arrangements. That's people living on a long-term basis with their shared lives provider. And we've had 16 short breaks arrangements for people who generally live at home with their families, of which, although we aren't an emergency service, we have been able to provide for people with urgent response in a crisis. Sometimes we can do that. So then the other number there is the people who live within a shared lives arrangement who also have a short breaks arrangement within shared lives. So they might go and stay with a different shared lives provider while their main shared lives carer is taking a break. In terms of the client group, so looking at the primary diagnosis, 56% of people have a learning disability. 86% of people have a learning disability, of which 30% have dual diagnosis on the autistic spectrum as well. 10% mental health, 4% acquired brain injury. Effectively, we can support anybody really who fits the criteria for shared lives. So the challenges we've been facing and some of the responses. So one significant challenge has been supporting providers to adapt to changes in legislation, bearing in mind that a lot of the providers have been offering this kind of service for many, many years under previously under adult placement. So how have we responded to that challenge? We were able to recruit some additional team members, and that enabled us to develop a really robust plan to support those providers and to put in place the quarterly monitoring visits. Sometimes it's more, but quarterly is really in line with CQC requirement. And we've also been able to develop, so Shared Lives panel. So what happens with Shared Lives is that we do a detailed and thorough assessment with our Shared Lives providers, and then they go to a panel which consists of some independent people for approval. And sometimes when we do the annual carer review, or even sometimes sooner than that, there may be some concerns which mean that we need to go back to independent panel for advice on whether to reapprove, deapprove, or put in reapproval with some criteria. We've been able to develop this year with working in partnership with the West Midlands Regional Shared Lives Panel, as well as in Herefordshire. So that's given a lot of oversight, independent sort of support and oversight. Another challenge we've had has been historically a bit of a low morale amongst the Shared Lives providers. And response to that has been this year implementing an increase to the board and lodgings payments that they receive, and an undertaking that will uplift annually now in line with benefits increases. And also we've been able to introduce paid carer breaks for up to 28 days a year, so that people don't lose all of their income if they need a break. There's been historically some inconsistency around effective engagement with all of the Shared Lives providers. They are self-employed people, and they are living in all different places around the county, and they may be very busy people with lots going on, and it has been sometimes difficult to engage with all of them. But we've been really pleased that in the last year or two we've been able to establish a friends group, led by one Shared Lives carer, who and they meet up monthly, and that's a vehicle for us to sort of link in as well. The other, going back to the theme of the day, the other challenge, of course, is the age profile of the Shared Lives providers, and the recruitment challenges that we have. So some of our Shared Lives providers are people who've done it for very, very many years and are well past retirement age. So we are looking for alternative ways to attract new Shared Lives providers, and would like to be looking at some website development. And nationally it's a problem that although nationally it's recognised as a really, really good model, the awareness of Shared Lives is low, really. So, you know, locally we're attending team meetings, working in partnership with all of our colleagues in social care, and we invite all new colleagues within the directorate, within sort of the social care teams, to come along to our team meetings. That's working really well, so they're getting to understand how we work and how we work in partnership. So future plans, so Shared Lives Plus review. So Shared Lives Plus is the national charity that we are members of, and they were commissioned to do some work with us this year. So they're working to review the scheme. So they've been engaging with our providers, with our staff, and with other stakeholders generally, to support the development and implement a strategy of growth and diversification. So the findings of the review, we have literally, it's hot off the press. The report has just been finalised. Within it, they've done a sort of mock CQC inspection, which is really useful. They've conducted a carer review. They've met with people with lived experience of receiving Herefordshire Shared Lives, and they've also produced a cost-benefit report looking at Shared Lives in relation to the other kinds of service provision. So next steps is dissemination of this report, and actually this Friday a visioning workshop led by Shared Lives Plus, where various of us and stakeholders are coming together to consider the report and what that means going forward. Also just important to mention that Shared Lives has also been conducting a home share feasibility study. So home share is a different model. It's not a CQC registered model, but it's a model where people who have a home and might have a spare room in it and actually could do with somebody around as a companion and possibly to provide them with some support, which is not personal care, but might be things like getting the shopping or walking the dog or doing a bit of cleaning, just generally being a presence to make somebody feel reassured that they're not on their own, can offer that spare room to somebody who might need somewhere to live, actually, in exchange for that help and support. So yeah, the householder and the home sharer, as they call them, share their home, their life, their times, their skills and their experiences. And benefits that have been reported are it helps a person to stay independently at home for longer. It provides affordable accommodation at a time of record housing shortages and high rent. And it provides individuals and their families peace of mind because there's somebody there. So stakeholder engagement is currently underway. And yeah, that's it.
Thank you, Ginny.
Okay.
I must admit this is an area that I didn't really get to grips with until about 2020 because we did have some concerns regarding the Shared Lives programme. I just wonder, and I don't know whether anybody else was thinking along these lines, how do we ensure that the people who are going to be sharing their homes are legally qualified, shall we say? So do we do checks on people?
With Shared Lives we're talking? Yes, we do. So all Shared Lives providers undergo a period of assessment, which is generally never less than 3 months to do an assessment. It's very detailed. All of them are DBS checked, and then we review that every 3 years, the same as the workforce generally. We get references, we get employment and character references for them. And each household has a designated coordinator who goes through that assessment process, gets to know the people really well, spends time with them, understands their household, how it's made up, who else might be in the household, just to be sure that everybody understands what Shared Lives is all about, that everybody is signed up to it, invested in it, and that it will work, and that the home is suitable as well. And then, as I say, we have to, under the CQC regulation, you know, we monitor all the time.
And I do think that changes in legislation and also the additional team that members that we've been able to employ have really helped us along this journey. Mandy just wanted to say something, and then we'll come to you, Councillor Thomas.
I just wanted to add that the panel process, particularly having that external support from other areas that, and having their involvement in the panel process to approve people in the first place gives that additional scrutiny. So it's not just down to our individual shared lives. We can bring other people in and make sure that we're being tested almost to make those right decisions externally.
Thank you. Councillor Thomas.
The first question was about the first element, which the people that take people into their home. I assume that they receive a fee for that. That's the first question. The second question, very practical. If most of these people for the second will be single people, so they get a rate allowance, of 50% rate allowance. Well, if they take somebody into their home, what happens about rate?
Council tax, you mean?
Council tax, sorry, sure I know, yes. council tax.
Yeah, so, sorry, so the second part of your question about council tax is that shared lives providers continue to pay council tax. There's no council tax relief for shared lives providers. They do get tax concessions.
No, I'm sorry. If you were if you're a single person living in your house, you get a rebate. So if somebody moves into your house to look after you or to as in this, do you lose that?
I think are you talking about home share, councillor?
Okay. To be honest, we're early days with home share. I don't know all of the answers. I'm sorry. In fact, I know very few answers. We're at very early days. Yeah. Yeah.
Yeah, I think what Councillor Thomas was suggesting is that, you know, if you are a lone person in a home, you get a 25% discount on your council tax. But if you take somebody in under this scheme, does that negate that discretion? Hilary?
Just to say on the home share, it is a feasibility study. So we're exploring all of those different aspects to see whether it is something that we could do in Herefordshire, and looking at best practice. So unlike Shared Lives, which is an established scheme that we want to grow, home share is something that we're purely at this stage just looking at the feasibility of. So I wouldn't want anyone to think that we were, you know, just about to launch it or it's in practice. It isn't. And these, you know, the aspects that you've raised are key questions for us in order to understand what's the risk benefit, I guess, of going ahead with it. But it felt like a good something that was worth at least exploring, so that we have the facts to hand as to whether we want to pursue it. I hope that's helpful.
Yeah, thank you.
Yes, because obviously quite a lot of elderly people, we were talking about elderly people, still live in quite reasonably sized houses. So, you know, in my case, we paid well over £2,500 council tax a year. So if you're going to, you know, so obviously that would be sort of, say, 1,800. If you're going to lose that by having somebody to care for you. So that's something obviously you want to consider. But obviously this would have to come under a national regulations, wouldn't it? So is this something that is sort of nationally recognised, or is this something that we as a council, Herefordshire, are pioneering?
Not pioneering. There are other schemes up and running and proving very successful in other areas. Hence, we want to see what that really looks like. But we're really at early days. But we're being assisted with that process with lots of good ideas that I heard only last week. So hopefully we'll be able to come back and talk to you again about the scheme in full if we're looking to, you know, launch it.
Yep, I think that's another one for our future work programme. Thank you. Councillor Tillett.
Thank you, Chair. Thank you, Ginny, for that presentation. It's an area that we haven't looked at, and it was about time a bit of light was shone. So thank you for shining that light. Now, in the slide where you showed the different health categories of the people who benefit from shared lives, you quote, and I almost quote you, well, basically we can look after anyone who meets the criteria for shared lives. I wonder if you would share with us what the criteria are for shared lives. Please, thank you.
Yeah, that's a good question. So effectively, shared lives providers take somebody into their home and they live with them. They don't provide 24/7 care. So they are matched. Some people are happy providing personal care, but it's very much about the match of the person with the shared lives providers. However, it is an ordinary household, so the expectation is that that person wouldn't need care at night. That person would have things that they do with their days, that they have a level of independence. It might be that they have day opportunities that they go to. It might be some people volunteer, some people work, and it would be an expectation that they don't rely on their shared lives provider round the clock 24/7, because they're not paid to do that effectively. But what they are is a safe and secure support for people, to make sure that all their needs are met, and like a family environment, but it's not a family. So in terms of what kind of support can we provide, what I was getting at is that we can support. It's not about the diagnosis. Anybody who would fit within a shared lives household is potentially somebody who could live within shared lives.
I think that's sort of what I was asking. What is it about any particular individual that makes you think, oh, I think this person could go down the shared life?
So, I mean, the great thing about shared lives is it stops people having to go into services. It means they can stay in the community and live an ordinary life like the rest of us. So it's great for everybody, really. So it is really about, thinking about when we're looking at assessing somebody, will they fit with an ordinary household? Will they be able to manage? Will the people, they won't have such complex needs that can't be met in an ordinary household. So a lot of people can fit within shared lives. It's about whether they've got, very high and complex health needs or night needs, or potentially there might be risks that can't be managed. Those are the things that would rule shared lives out, really. Yeah.
Ginny, I think Mandy wanted to come in on that, and then we've got Councillor Dykes after.
It's okay. I was just thinking to give you a couple of examples of when this can work for individuals that are eligible for health and care. So you might have somebody who currently is struggling living independently, but actually don't need that 24-hour care of going into a residential home. So something like shared lives can offer you that rich alternative to living as independently as possible, but with some family support. So that's sort of one example. Can happen the other way as well, that somebody actually who's been having quite a structured life within a residential home is wanting more independence, and it can act as a really good step down to try to be closer and more inclusively in the community. And that's worked really well as well. And what I've seen is that people's lives becoming really richer in a shared lives community, even at the point of where, I know of one family who cared for the individual who actually was diagnosed with palliative care, and they maintained him up to his death, because they become so fond of him and cared for him, with obviously services coming in. So you can see real benefits for people who's choosing that kind of environment, and those caring and supportive people who really put themselves, make themselves. I don't know, there's something special about our shared lives carers that have so much to offer.
So potentially quite more possibilities.
Absolutely, and that's why we're wanting to look to expand the service.
Yeah. Except it does call for some fairly extraordinary people at times, I guess.
It does, it does. But there's plenty out there in
Herefordshire. Oh, yeah, absolutely. Thanks.
Councillor Dykes.
Thank you, Chair. You say, and this looks like it could be a really, really important service to keep people out of care homes, hospitals and that. And you say one of the challenges is recruitment. What are you doing to actually recruit these people, and what figures are you looking at? Do you need to, you're looking at a number of people to recruit?
So we're, as parts of Shared Lives Plus, coming in and doing some of this exercise of work with us and consulting with a whole range of stakeholders. We're also looking at what communication plan that we need to put in place to attract different carers for different things. So some people might prefer, for example, for those that short short placements. That might be for me, if I was going to do it, that might be something I'd be interested. You might be interested in absolutely a wider commitment if you were going to do it. And so it's really making sure that we've got the key messages about the different types of developments we want for a scheme, so that it can attract the right carers to the right kind of service that we want to offer. So Ginny talked about sharing days. So somebody sharing their home for a day might be something that they'd like to do. So which would add day opportunities and of a different type to what we can offer. So that's the kind of thing that we want to do. And of course, we've got communications team who's all ready to roll with us to make sure that we get a plan in place to get out there and advertise. But we really want to target the types of provision that we want, type of carers that we want.
There seems to be a theme about recruitment, retention, and all that goes with that, which we all understand is a really laborious task to do. Councillor Davis.
Thank you. A question on the age demographic of the clientele base. Is this aged 18 to 70, or are we looking at older? I mean, does it depend on their capability? As in, if they have learning difficulties or physical or other conditions?
Doesn't depend on what the diagnosis is, as Ginny said. It does depend on the carers, what they're able to accommodate in terms of care and support. I mean, as I said, some carers somebody might be well able to cope, and then something might happen and people might deteriorate, and either the carer will take a decision that with help they can continue providing that support. Unfortunately, sometimes it's not possible, and so then you'd look at an alternative arrangement, perhaps that step up into a residential care placement, for example. Age, no, there's no age barrier. So it could be older, frail people that could take advantage of shared lives, absolutely, especially if they felt that they didn't want to go into that wider care home. A placement in a shared lives might be absolutely the thing that they might choose to do.
Thank you, Councillor David. Any other questions on shared lives? No? Lovely. Well, it's been a very informative afternoon, and what I think we need to do now is thank you all for your input, and let's have a look at what we've sort of thought about to add to our programme. So I think on the work programme side of things, we are considering bringing back Discharge to Assess, bring back their team with Wye Valley and Hoople. We definitely would like more from you in shared lives in the future, and perhaps I think as a way forward, could I suggest that an action for us as a committee is to invite providers of home care to come and have an informal meeting, so that we can see if there's anything that we are not adhering to or meeting. Would you agree with those? Councillor Bartlett?
Definitely. And I was just looking at, towards the end of the report, page 32, 4.33, when it talks about the future plans for the current framework for home care, talking about the transition to the new models, talking about the sufficiency and affordability, etc. I'm just wondering whether, when they're talking about establishing a project within the Community Wellbeing Transformation Programme to review and further develop home care solutions, and these are the wider ones and the more transformative ones that we've only just touched on, whether that is something that we want to look at. And it's almost, in a way, those type of things are almost starting to coalesce into like a task and finish into what is our future. Just an idea.
Daniel, do you want to comment on that?
No, absolutely, and I would agree with your observation there. If that's something that the committee wants to explore further, I would suggest that the place to start would be beginning to pull together the terms of reference for that, so you can gather your thoughts on what that might cover and what its objective might be. Just a couple of pages, and I can certainly start that process if you'd like me to.
Yes. Yep, that would be super, thank you. So that's the end of that agenda item. So the recommendations were that scrutiny consider the report and note the progress, which I think we've done, and to determine any recommendations that we wish to take to the executive. I don't think there's anything specific there. I think we've already highlighted the way we're going to go with those actions and work programmes, if that's okay. Okay, so again, thank you all very much, and we'll see you anon. Right, so we're going to move on. If officers want to leave, that's fine. Otherwise, you can stay in. They're gathering their stuff quickly.
That says it all. Very quickly. Waiting with the feet. Anyone?
We're just going to move on to item 8 on the agenda, which is the work programme. The draft work programme is shown in the agenda pack, pages 43 and 44, and this is to be considered by us as the committee. Daniel, do you want to say anything to start that one off?
It just really, it is what it is. Obviously, you mentioned earlier around the future of care and community services, and indeed we are looking at community-based support services in January, though I would argue that's probably a more short, medium-term item, and doesn't clash with any sort of task and finish group. Obviously, as well, we will start work on the briefing session as well with the care providers. I'll approach the West Midlands Care Association and see if they can pull together some people who might want to contribute that with you. What I will do as well is noting that tomorrow the Scrutiny Management Board will be looking at the corporate workforce strategy, so it might be worth your while, Chair, taking the issues that the committee have raised around workforce to that. Obviously, I get to sit in a lot of scrutiny meetings, and the topic of workforce seems to come up at every single meeting, so I think that would be a very useful reflection to take back tomorrow.
Yeah, thank you for that, Daniel. So we've all got the agendas in front of us. Oh, Councillor Bartlett.
Yeah, I was just going to leap straight into the agenda, if that's okay. Just thinking ahead, towards the end, we've got of our programme so far for these 4 years. On 20th of May 24, we've got the West Mercia Police Most Appropriate Agency Policy. And I know we've spoken before, both of us, about mental health provision. And quite often some of the stuff that comes up at the Mental Health Access Forum. It strikes me, do we want to take at some point in our work programme a closer look at provision of mental health within the county from our provider, who's now four years in? 4 years in? And forgive me, Chair and Vice Chair, I don't know when mental health last came to this committee.
I can't speak for this committee, but Children and Young People Scrutiny Committee had CAMS come into their committee last week.
Yeah, and flip side of that is, you know, we've got adults and then we've got the all ages provision, haven't we, for the transition? And some of those, particularly like the autism strategy, we know is for mental health support, is slightly under resourced. It would be good to know how adult mental health provision is doing in the county at the moment.
I think you might have actually hit university on a couple of topics there at the same time. I think certainly when CAMS came in, they were very keen to differentiate between mental health, mental illness, and neurodiversity, and I think that as you look at adult services, the transition into adult services, and some of our responsibilities, particularly around housing, you might well find yourself uncovering two or three quite discrete topics, one around medical services, clinical services provided by the NHS, and another around housing strategy going forward for two or three very distinct, discrete cohorts of residents that we have lifelong duties of care towards. So I think, again, it might warrant a bit of time thinking through what it is you want out of those items.
Yeah, and at some point, I'd like within the work programming structure to say, to dig down into that topic and say, is this something that we need to look at? As I say, we're up to May 24 here, so we're definitely pacing ourselves well.
Yeah, and we've already highlighted it on the March meeting as well with the supported housing for adults, working adults with additional needs. So that's including the enduring mental health concerns. So yeah, we'll take those notes forward. Thank you, Councillor Bartlett. Anything else for the work? Oh, Ivan, sorry, Councillor Powell.
Thank you, Chair. This is designed to, or this is intended to be hopefully a helpful offer. So, obviously I'm the Cabinet Member for Children's, but you'll be aware of some of the other professional roles that I hold. Nationally, the police most appropriate agency policy, some areas call it right service, right time, is under a whole load of scrutiny in a number of areas, but notably through the national network of independent chairs of safeguarding adult boards. And just by pure coincidence, I'm going to the College of Policing tomorrow to do an input on adult safeguarding and policing, because there's no national policy for adult safeguarding. So there's an offer. If you wanted me to help inform that agenda, I'll gladly do so.
That would be amazing. Thank you. We'll definitely take you up on that offer. Thank you. Any other comments or additions? No. Okay, so I think we've nearly come to the end. So the date of the next scheduled meeting is Monday the 29th of January 2024. So I'm going to see you all again before then, but those of you who I don't, have a happy Christmas. Thank you. Could I ask that the live stream is discontinued, please?